Alan Johnson serves from ESO Solutions. Alan Johnson serves as the Vice President for Health Data Exchange and Analytics for Austin-based ESO Solutions. Alan has been active in the EMS as a paramedic, educator, and administrator for almost 3 decades. He led the Montgomery Council Hospital District in Texas as the EMS Director and CEO for 14 years. Most recently, he spent 3 years at HCA in Houston. Alan is known for his focus on clinical performance measurement and improvement. Alan obtained a BS in psychology and a master's in public administration from Texas A&M University. Alan and his wife Kristen and children reside in Bastrop, Texas. Thank you, Alan.
Thank you. Well, I guess it's officially good afternoon. I really appreciate being here and having the opportunity to visit with y'all a little bit today about a little bit of what we're doing over at ESO in partnership with some of the local health systems here and local EMS agencies, and then the same activity that we're replicating in various parts of the United States. Apology right up front, I'm coming off of about 3 weeks worth of cedar hell. I'm no longer snotty, which is a great thing, but the bronchial tubes are still a little averse to talking a lot, so we'll see how that goes. So to start off, ESO, we are an Austin-based health IT company. We're located just up on 183 up near Mopac. We've been around 11 years in the pre-hospital environment predominantly. So ambulances is really our sweet spot where we've existed over that period of time. About 1,600 customers across the United States. We're one of about probably 4 or 5 large EHR vendors in that pre-hospital market. We're up around 100 employees. We just surpassed 100 employees. It is a fun place to work. We are known for our culture. We were named one of the top places to work in Austin this past year. Our database of patient records has surpassed really 21 million this past the end of the year, and so it's a pretty decent repository. Our mission that we focus everything we do around is trying to help our customers improve community health through the power of data. One of the things that made us kind of unique in the market a number of years ago. Certainly many of our colleagues in the industry have started focusing more on data and how we make data actionable for our customers and for the improvement of patient care. Our product line is, we have a large product line around applications for public safety and healthcare in that pre-hospital environment, including a fire reporting package. About 40% of ambulance transports in the United States are done by fire-based systems, and so you have to be able to meet their needs in the suppression side as well as the patient care side. More and more, you're seeing in fire departments that suppression side is less and less of what they do, and more of what they do is healthcare, whether it's the 911 side and many fire departments across the United States, many ambulance services in general across the United States are starting to focus a lot on that unscheduled out-of-hospital healthcare. So taking someone with a chronic condition and helping them to negotiate their way through a healthy life and try to keep them out of the hospital, where obviously some of the most expensive care takes place, and it's a limited commodity. About 4 years ago, maybe close to 5 years ago, we started working in interoperability space. This came as a result of, like many things do as you're looking at changing and evolving, at a conference with colleagues over adult beverages, there was a conversation with medical directors, some very esteemed medical directors across the United States. What is it that you need to help improve the practice of medicine in your service? And the resounding response from them was, we need outcome data from hospitals. We need to know what happened to our patients. We're being asked as clinicians to steer patients to alternate destinations. Well, how will we ever do that if we don't know if our paramedics can pick out patients who are appropriate for that alternate destination? And we only know that retrospectively after other clinicians and laboratory testing and imaging comes back and say, yep, that was a low acuity patient. And there's so many other reasons why they wanted that data. So we packed up and went to our hospital colleagues and said, gosh, medical directors would like to have outcome information. What's the carrot that you need to be able to provide that? And resoundingly, the hospital said, we need their data. We need to understand our number one referral source. We need that patient care record. Currently, we have a hard time managing getting that patient care record to the ambulance record to the hospital chart. It just doesn't happen very often, and that data is so important for them. And so we said, wow, that sounds like a marriage made in heaven. We started working on the interoperability platform to make that occur. And that's what we're going to talk about here in a few minutes. And then the third leg of what we do is health analytics, primarily around the emergency space today, but we're taking that giant leap now into that larger healthcare analytics, looking at population health and trending of chronic conditions, and what does it take to create a healthier community. So a couple things to point out. This area is really getting a lot of attention these days. The federal strategic initiative out of ONC recently published, I guess a few months ago, mentions EMS, I don't know, like 30 times in there. It's all over the place, recognizing that EMS is an important component of that health system. The fact that we have these folks out who are touching the patients at the bedside, we know what's taking place, disasters and things like that. How do we better integrate the data that they have into the larger data scheme? And how do we take the data from hospitals and physicians and so forth and make it available for Bob the paramedic at the bedside when he's got that patient? And so we not only have the strategic plan, but we have places like California, who's almost a $3 million grant out to develop the tools to allow a paramedic to search for patient records in the field, surface that data so they can determine what's wrong with this patient, where this patient needs to go, and so forth. Be able to alert the hospital and send any data EMS has to the clinicians prior to arrival so that the physician can have that information to help make decisions, and then to be able to take the EMS record in, consume it in the EHR, and provide outcome data back to EMS. So a little bit about EMS data. People are often surprised, especially hospital-based folks, IT folks are surprised to find out how long EMS has been collecting data. I did my first electronic chart in 1986 on a Fujitsu, I think you put one patient record on it before it died, device, and moved on to hammerheads and tough books, and now we're doing them on iPads and so forth. But EMS has been collecting data in a structured format for a long time, long before hospitals did it in mass. In fact, there is a National EMS Information System data set, about some 600 data elements and thousands of coded values that everybody in the United States uses. And so it is very easy to pull data from various EMS sources and consume it. It is fairly easy to bring that data together and use it for analytics. And so pretty special that we have that. I wish everyone had the same thing. EMS Compass is a project that's going on right now. It's a national benchmarking exercise. So to take that uniform data set and use it to measure performance, likely pay for performance in the near future for the EMS industry. So there's always been this desire to link EMS data to hospital data. When you look across the Joint Commission, who actually requires it, and you look at the disease-specific certifying bodies for stroke and STEMI and trauma, they all say that you need to be bringing the data, the care needs to be aligned from 911 through ultimate discharge of that patient. Everybody should be singing from the same choir book. Makes sense, right? Things that we do in the field should dovetail what's done in the emergency room. What's done in the emergency room should carry over to inpatient, ultimately through transitional care and so forth. That has traditionally not been the way it's done. It's been done in silos. And so there's a big focus now on aligning care plans and protocols to doing joint quality improvement, bringing paramedics and doctors and nurses in a room together and talk about how do we make this work. You see the ads on television, right, for stroke and for heart attack and so forth. Look at those signs, reduce the time from time of onset to time of treatment. Well, you do that, one, by patient education. They got to know when to call. But when they do call, to have a system in place where everybody works and plays well together. And we do that not only by planning together, but then looking at our performance together in a unified front and being able to make it better. So that all sounds really good, but I will tell you that that soup to nuts, through loop closure is a very difficult process, operationally and from a data standpoint. So what is typically lost in translation is this EMS record. So many times across the United States, the record still today, there's a paper component to it. There are people out there who are still charting on paper. Not many of them. It's pretty rare to find one. We're talking to a major, one of our sales reps recently about a fairly large county in another state who was a possible customer, and I said, well, who are they using this? They're on paper. I'm like, God, you're kidding me. And this agency does like 50, 60,000 ambulance responses a year. They have no way of knowing how they're performing clinically. So, but even still, even if they're electronic, it's getting printed out, and Paramedic Bob is handing it to Nurse Susie, and hopefully Nurse Susie takes it and gets it to the patient chart. It goes over to medical records, where someone in medical records is going to scan it, index it, and hopefully attach it to the right patient chart. The other way that it gets there is that it comes in by fax. So when they close their record, it automatically faxes in, or worse yet, it requires Paramedic Bob to go to the fax machine after he's printed it out, loaded it in, and send it to medical records. Or there's probably a dozen websites, depending upon who the agency is, that the hospital has to go into, log into, bring it up. If they're lucky, they can save it electronically and suck it into their EHR, but most have to print it and scan it and index it and so forth. And so you see this type of stack sitting in medical records today. And consequently, as we looked across the United States at various hospital systems, the good ones are only getting the EMS chart to the patient record about 25 to 30% of the time. It's a miserable failure. And AJ here with Seton has a project she wants to do this year that helps integrate that EMS data all the way into their registries, because that registry function is so important for the hospital. It's so labor intensive, but it's really not that labor intensive if they never have a chart. It makes it quite easy, actually, but it defeats the purpose. So the solution is to connect, is to bring that data together in an agnostic approach. As I mentioned, there's a bunch of EMS data providers out there. We're not the only ones. And so hospitals have a finite amount of resources. They can't go connect to every vendor for every agency out there. They need an agnostic solution that can catch it from everybody, bring it in through one pipe, and make it work. So we're gonna get a one-to-many connection. We're gonna remove the paper, make it flow data-wise, and then hopefully be able to embed that data, not just make the data viewable. So today, most places that we're working with are bringing the PDF of the record in. They click on a button and bring it up in the EHR. So that's viewable data. What we really want to be able to do is make it consumable. So it's actually filling in the appropriate fields in Cerner or Epic or whoever they happen to be using. So now we can cut out that step of how many milliliters of fluid did you give? How much aspirin did they have? What was their temperature? What vitals? What was your blood pressure? Lots of opportunities for data entry errors. So how does it work? Our process, we advocate capturing the episode of care number at the hospital. Our HIPAA use case around this is under limited healthcare operations as well as reimbursement. But the limited healthcare operations is tied to the episode of care. The hospital needs the record, the ambulance record from that ambulance transport. The paramedic and the medical director need that outcome data for that visit. Not the entire longitudinal record. That's a whole different HIPAA use case, and I will tell you, much more difficult to get the players to agree upon. But this exchange for specific treatment, payment, and operations for that visit is very doable. And so we capture the episode of care number. We put it in there. That's what the hospital's going to match off of. So we get a very, very high match rate with this. And this is the data that goes back and forth. On the EMS side, we're sending to the hospital all the vital signs, procedures, assessments, very detailed data on what was done for this patient. Their meds, allergies, their history, everything that's collected in the field goes over to them. On the back side, the hospital is sending back demographics and billing information, diagnosis, disposition, so we can know what's wrong with them, how sick were they, what happened to them later. And then we start getting into finer clinical details. So vital signs, pain scores, lab work, blood alcohol levels. Did he have a head injury, or was it the tacos, beans, and beer that he had for dinner that made him a little bit loopy? Well, it's an important differentiator for them. Looking at imaging results coming back. So lots of detailed data that helps the medical directors see what were we dispatched to? What did we think it was? What ended up being at the hospital? And now I can get down to the fine points of how close was my assessment related to what the hospital found. We thought pain, control of pain is a huge issue in healthcare today. Big emphasis on it. At the same time, there's this huge emphasis on healthcare. There's this huge emphasis from the DEA going, whoa, y'all shouldn't be using that stuff out in the field. We're giving too much pain meds. And so the doctors are at this place where, do I give too much? Am I not getting enough? Now they have the ability to start looking at that. Are we truly controlling their pain? Are we taking the edge off and making them comfortable during that ride to the hospital? And that data at the hospital helps back it up. So our approach is, as I mentioned, vendor agnostic. We've integrated with most all of the large EHR vendors for the hospital, and we take data from all of our competitors as well. This is an example from Epic of what it looks like. When the patient record slides all the way through, it ends up in a results queue. They can click on it over here. They'll hit View Image, and in a native PDF viewer, the record will come up. This is a Cerner example. Again, same situation. We're in the Results tab over here. They click on it. Notice there's multiple ones. It is not unusual for paramedic Bob to close his record and go, I forgot something, and they go in and put it in. Well, very important on the hospital side is that clinicians have made decisions based on a record that was provided to them, that the historical layers are there. And so we give them the ability to see that. But it's just popping up, again, viewable data for them right there at the bedside. This is an example of a tracking board. So in an emergency room, and little ambulance popped up. Oh, shoot, the bill didn't work. So little ambulance up there on the top blue line, they click on that little ambulance, it's going to pop up the record there. That's their indication that it's there, just as they have indications they have lab values back or RAD results or whatever the case may be. So why do the hospitals care? Why do they want this? What would a healthcare system do with a bunch of paramedics? It's just ambulance drivers. Why would I need that data? My tongue almost snapped off on that one. And in fact, if this is recorded and is viewed by any paramedics, I will be a marked man for that comment. So why would they want the data? One, it's continuity of care. Continuity of care is so important. There are so many things that we do, again, that continuum of care that we're doing in the field that impacts care in the hospital. If the paramedic has already given them something, drug X, we really don't need to follow it up right now in the hospital because now we put the patient's safety at risk. Risk mitigation. Going back to continuity of care, we have a couple sites that came to us after they had an adverse event. Physician had a patient, thought to be low acuity, released the patient to go back home. The patient had bad outcome. EMS record shows up 3 days later. He looks at the record and says, oh my God, had I known this patient never would have gone home. So we've got 3 documented right now. We got a call from a major healthcare system on the East Coast this last week. They had one last week. They want our system. They want that record in so it's accessible to the physician. Disease-specific certifications. All of those bodies that come in and tell the hospital whether they're doing a good job or not, give them that certification as a stroke center or a STEMI center, all promote systems of care. All require loop closure with EMS. All require joint PI. All of them have registries that have pre-hospital data, and a lot of it. Well, the hospitals employ abstractors who sit and pull records, manually abstract it, find that data, and punch it in. Well, again, finding the data is the hard part. And so if it's piecemeal work. If they have so many patient touches they have to do in a day, if they can't readily find that record, then they move on. And they don't have time to go out and call the chief and say, hey, can you fax another copy of that record in? Oh gosh, I don't know if it's that service or the other service. Which website? Do you have your login? I forgot my password. You know how that stuff lays out. And so having the data come in and be resident inside the EHR where they're already working is very important. And our goal over this next year is to make that where they don't even have to abstract it anymore. If the data is already in the EMS record, then it's going to bring in and populate the fields in the registry for them. And consequently, I think it's going to open up the door for us for additional outcome data to come back from the hospital that will help drive QI processes. So the hospital has measures that they have to report on. You've heard of core measures, hospital grades, all these different things. So if I'm a hospital, I have a certain requirements that are, some of them are government reported, some are just internal benchmarks that they have to achieve as they're graded across their systems. One of those is pain control. So if you come in, with the, let's say just hypothetically you break the tip of your elbow off, and you're brought into the hospital, and you're in quite a bit of pain. I'm just hypothetically thinking you're in a good deal of pain. Right. So the hospital is going to grade your pain when you arrive. First thing they're going to do, they're going to take your vital signs. They're going to say, how much does it hurt? On a scale of 1 to 10, how much does it hurt? And you're going to say, it's a 45. Right? Well, you are going to get pain meds. They're going to offer you pain medication. And they're graded on how fast they do that, and then how they control your pain over time. And so patients like me who come in who are not thinking straight and go, now I'll wait, really mess them up. And then 10 minutes later, I'm like, wait a minute. That would be a really good idea right now. Collarbone, of course, issue. And so EMS medicates the patient 10 minutes outside the hospital. They juice them up pretty good. They don't snow them. They're still alert and talking and so forth. They get to the hospital. Hospital says, EMS gave you pain? Fantastic. Is it controlled? Yep, I feel pretty good. Happy days. Where do I sign? Let's go get this fixed. All right. Nurse does not document that EMS gave pain meds. Right? We get past the threshold of an hour, and there's no pain meds documented. There's no EMS record attached to the chart to prove that EMS did it. Hospital gets a 0 for that one. They did not control the pain. They didn't need to. It should have been excluded based on the fact that EMS gave it. Another example, aspirin and chest pain. One of the most important, talking to a famous cardiologist in Houston who said, I asked him the question, of all the treatments that are out there for a heart attack, if you were having a heart attack on a desert island, which one would you want to have? So I'm thinking that's the one I'm going to get when I go. And he said, aspirin. It's the single most important thing you can have in an ischemic event. And so if EMS gives aspirin, should the hospital give aspirin? Nope. And if it's not documented, did the hospital do it? Those of you who are clinician or clinical background know if it's not documented, it wasn't done. Is that the rule? That's right. And so when they don't have it, and that one has been passed a core measure. And so that one directly impacts funding. And so, it becomes important. And then we'll talk about the gold mine of business intelligence as we move through here. So speaking of business intelligence, this is actual data from my old stomping grounds. This is EMS data for a particular hospital system plotted on a map. And so we provided this service for our hospitals because we wanted them on our good side. We weren't always on their good side, but we wanted them on our good side. The hospitals want to know, where are my patients coming from? So I really want to know where my good paying patients, my patients with a payer source who fall into certain DRGs are coming from. But we wanted to, we segmented this for them. But wouldn't it be fantastic in the hospital system to be able to plot my patients where they were picked up? The hospital knows where they live. They don't necessarily know where they originated. Well, we can give them where they originated. So when are they driving past the competition to get to me? And we collect why the hospital was chosen. So why are they driving past the competition, from where and why, how often, with what problems and what payer? So all of a sudden I can start looking to see where my insured stroke and STEMI patients are coming from versus the distribution of my uninsured overdoses. And all of a sudden you go, one is higher than the other. What is that telling me? We obviously might have a problem with our relationship with EMS. If EMS is consistently driving past the competition to bring me folks who are going to clog up my ER who don't have a payer source. It's odd, but it does happen. And so knowing that information is really important. And so looking at it by service line, by payer, by reason, and so forth, great to be able to throw up on a map. You don't have your competition's data, but you do have yours. You would be able to have yours. Another one, here's the reason we were selected. And this looked at all transports versus cardiac patients. And it's interesting that for most patients, it's closest facility. Just take me to the closest one, get me there, get me done. But when it came to cardiac patients, the number one reason was the hospital was a specialty source. They had run the ads on 6 o'clock and 10 o'clock news telling everybody how good they were at cardiac. And people were asking for them for that reason when they had a cardiac event. So systems of care, I mentioned that before. This is from the Society for Cardiovascular Patient Care. Their accreditation standards talk about EMS and the facility recognize that EMS is an extension of the care in the hospital, and that they need to have a seamless working relationship in all these different areas. So how can you surface that? Here's one. One of the things that is really important for someone having a chest pain is to get a 12-lead EKG. Everybody probably is familiar with that, what it does. I liken it to watching Monday Night Football with one camera versus 12. You know, when you see it from 12 different views, you have a much better opportunity to see whether that was a fumble or not, or in this case, a heart attack or not. And so we want EMS to do that. In this case, this is from a real live agency. Over 11,000 patients, 90% of the patients with chest pain over the age of 35 got a 12 lead. Why isn't it 100%? Well, we could drill down into this and find out. But that's valuable information to a STEMI coordinator who can look at the information by EMS agency. Who are my star performers? Who are not? And if we have agencies that are not getting a 12 lead in the field, go out and do education with them. Here's acquisition time of that 12 lead. So in this case, 80% of them are done in under 10 minutes. That's actually pretty good performance when you think about it. You got to pull up around the house, tell them you're on scene, get in the house, do the skill and so forth. We'd like to see that time compressed. The cardiac event time is important. Outcomes reporting for the hospital is another thing that that continuity care are required to do. Report back on certain types of cases to the providers what was wrong with them. That's a very labor-intensive process. In this case, we've actually gone out in a couple different places and looked at the time it takes to do it. On the right-hand side are the steps for the hospital to get an outcome out the door. Going and abstracting the information, creating a form, eventually they have to turn it into an encrypted email. They have to send that encrypted email to the correct place, and then in the end, EMS has to do their things. It's a time-intensive process. Wouldn't it be nice if it's automated? And we've done that. So this interoperability device provides a portal to the providers and the medical director so they can see not only those hallmark cases that everybody wants to know what was wrong with them, but every case. It's those 40-year-old females having anxiety, just this low-level anxiety that everybody kind of blows off, that they get to the hospital and they find out, oh my gosh, she was having a cardiac event. Paramedic needs to know that, right? We need to understand how often those silent MIs that take place in middle-aged females are actually taking place. That's huge, valuable data to go back. And so this reporting tool is used on every patient in the hospital that's brought in by EMS. It's used to send a defined data set, which Ethics and Compliance likes. Those of you who work with HIPAA data know that the HIPAA police are out there and they're really serious about what they're doing. And we thought that they would really have a problem with this until we explained to them that it was an automated process, that it was a defined data set. You pick the data set, we know. You do, you approve it. It happens every time. There's no freelancing. So Nurse Ratchet can't say, yeah, the mayor's daughter, yep, she was here, she had a broken ankle, and did you know she's pregnant? It happens. I can tell you the number of cases like that where data leaked and then it just goes viral. We need that not to occur. And so the compliance people like this from the standpoint that, again, it's secure, it's auditable, it's trackable, it's a defined data set, it cuts out those manual processes, and HIPAA absolutely permits the sharing of this data without the patient's permission in this type of secure environment when related to, obviously, treatment, payment, and operation. So the EMS physician. The EMS physician is for most hospitals, the number one referral of patients into that hospital. EMS Medical Director, who oversees the paramedics who operate in a critical community, they operate under his medical license. He actually develops protocols on when you have these sort of conditions, here is where you take these patients. They're very interested in how their patients do. They're interested in that collegial environment and so forth. And depending upon the state, this happens to be about Texas, but it's pretty much the same under most states. They all are required to approve the local standard of care, to monitor performance, to pick destination, to monitor compliance with their treatments, and to work with the hospitals to improve patient care. And so the hospitals want that good relationship with that EMS medical director. and the ability to fuel those processes that by law, I mean, this isn't regulation, and this isn't some certifying body. This is state statute that says this is your job as a medical director. And so in the absence of having that data come back, they can't do their state mandated job. So one last report I want to show you. This is when you start colliding EMS and hospital data, some really interesting things happen. You start seeing things that you maybe suspected were the case, and sometimes you're really surprised. And this is one of the areas where we were really surprised. We started pulling data across a number of organizations, and this just happens to be one of them, and it's 359 patients over about a year and a half. This is an agency on the East Coast, actual patient data, blinded. Obviously, you're not going to see any particular patient. Where we looked at patients who were admitted to the hospital with a diagnosis of stroke. So in other words, somebody who had access to labs and imaging results and a more detailed patient assessment in air conditioning and under nice lights and so forth. So I think this is a stroke, let's admit them to the hospital. When we compared that to what the paramedics thought was wrong with them, we were surprised to find that paramedics, and this is high performance, this is very high performance, only pick up the strokes 55% of the time. The average performance, as we looked across all of our agencies that participate in this, is about 38% of the time. Why is that important? Stroke is one of the few things where time really matters. If you wait with a stroke, every second you wait, your brain continues to die. Well, there are treatments out there. There's a drug that they can squirt in your vein, and it can go in the right circumstances. It can dissolve that clot, reopen it up, and you wake up like nothing wrong with you. That's best case. In most cases, you have maybe some minor deficits, but you have a return to a fairly normal life. In the absence of that, in a comprehensive stroke center, you can actually go in, and they have this little corkscrew they can wind through your groin up into your head, and they screw it into the clot, and they pull that clot out. And blood starts flowing again. They can do a number of other procedures. But time is critically important. And in the hospital, we would like for the ambulance to recognize the stroke and say, hospital, we're coming in with a stroke, be ready. And the whole team is there ready to receive that patient. You've seen like a cardiac arrest coming in. You've seen a gunshot victim come in. A stroke needs that same level of urgent care. Well, when the paramedic doesn't pick it out, what happens? The patient arrives, they go to the triage desk. Well, you're kind of having some funny symptoms. Okay, well, let's get you checked in. And then we move you over here, and someone finally goes, gosh, I don't like this. I think this might be a stroke. And they call a stroke alert. We miss 10, 15 minutes sometimes. It's longer if there's more ambulances stacked up waiting for the triage. And so what we found is that when you look into the no matching clinical impression, what we find is a whole lot of patients with very predictable signs, things we should have known. Generalized unexplained generalized weakness, sudden unexplained generalized weakness, headache, altered level of consciousness, dizziness. Oh my God, it's all the symptoms of a stroke. And so what we're finding is when you collide this data, you start asking questions about, should we change our protocol? Should we not wait for the patient to be screaming stroke at us? Should we look at these sudden unexplained signs and symptoms and go, until I prove otherwise, I'm going to assume this is a stroke, do the stroke alert, and get those processes, boom, boom, boom. And if it's a happy time, oh, you've got the weakened disease? Let's go address that. We've ruled a stroke out. Let's go do this other thing. At least we've sped the case. And I think as we continue to collide EMS and hospital data together in this format, we're going to find all kinds of ways we can better patient care. This is just one of them. So just a couple quick examples. A 17 alpha, when you're dispatched with 17 alpha, that's a fall victim. No low priority, no lights, no sirens. Go pick them up, get them back in bed, whatever. They diagnosed as a traumatic impression at the hospital. They found a C1 cervical fracture. If you were the medical director, would you want to know that? Probably. Another low acuity fall. Well, let's just get through. That's actually a ceiling. So they arrive. This happens all the time. If you've got an older family member at home who falls, don't assume they're just fell and they're okay. Make sure. So this patient was an older patient who had fallen overnight, had been drinking heavily, had a drinking issue, had diarrhea, vomiting, probably a really bad, ugly situation. Paramedics arrived, lifted the patient up, pivoted him over, set him in an office chair, and rolled him down the hallway and put him in. The diagnosis was pathological fracture of the neck femur. So, great learning event for that agency. It happens all the time. Should it happen? Should you take a shortcut like that? Probably not. So anyway, the hospital data, in short, is just invaluable for EMS for all the reasons here: strengthening the relationships, access to the EMS record for the hospital, reducing those processes, fueling business intelligence. We think there's a huge play here for population health, bringing that out-of-hospital data together and making it available back to the paramedics when they see those patients again. And then the impact of our solution and others that are coming in the market like this, that low impact on IT because you're doing it one time in and bringing it all in. I'm happy to answer any questions. Mm-hmm. Exactly. So a couple ways. So there's a couple ways. So I'm going to talk about our narrow solution versus probably the wider answer. Our solution, short term for that, in places in the absence of an HIE, is to ask the patient, can we share this record with your physician? If they authorize that and we collect the physician's name, we want to be able to shift that record to Seton or to the physician EHR so that they have that. The better answer in that, in our solution, is not an HIE. We don't purport to be an HIE. We're an episode of care solution right at that. But what we're finding in many communities is there is an HIE. And so our solution is different than that. They want our solution to get the outcome information back, get the record straight to the chart, so that the hospital has it available in Cerner or Epic or Meditech or whatever, as opposed to just querying it off the HIE. But that EMS record should go also to the HIE, so that the clinician has access for it. And HCA is actually going to do that for the transports, but you're exactly right. Those no transport calls are just as important. We may transport the diabetic 1 or 2 times a year, but they may call the ambulance 12 or 15 times a year, and the physician never knows that. Behavioral health is its own special area, and its own special, I mean, it's a difficult clinical area, but it's difficult from an IT standpoint as
We're recording this and we're broadcasting it, so just.
So your solution works well in areas that have broadband readily available. How about those other areas that broadband may not be available? Or
Great point.
Cell phone? Are you using cell phone technology to transport that information to the receiving hospital when you're en route? That's one question. And two, and if you are, how do you do that when there aren't that many cell towers around in a white space, if you will, of Texas?
Sure. So let me answer your question a couple of different ways. Number one is our platform does not rely. We have a mobile application for our EHR platform. You have to have that in the ambulance world. When Hurricane Ike comes through Galveston and there's no power for 2 weeks, the ambulances still have to go and they still have to chart. So they have to be able to chart in a mobile environment and then upload later. But you're exactly right. If you're going to do real-time data, you're going to rely on cellular network primarily. Those have gotten much better as they've obviously moved to digital, and the mobile gateways that are on the ambulances are much more robust than they were previously. But there are places in the United States where that's going to be a challenge. Absolutely. But getting the record to the hospital once they get there, so that would affect the pulling down on scene as well as the alerting of the hospital, but it would not affect the filing of that record and getting outcome data back, because they'll hook up to the hospital when they get there.
To follow up on that, there's an effort, I think it's called Industrial Internet, and it is a standards-based thing that the large IT companies, IBM I think is involved, Motorola, they have 24 scenarios for you call it, I don't know, smart cities or mission critical or whatever type of that, and one of them is yours. Are you familiar with that effort?
I'm not. I know with respect to, I know there are places that currently run data across the Motorola or Macom 800 megahertz networks.
No, they're looking to future type capabilities.
I
Like
see.
her particular situation would be something I'm sure they're going to want to solve, and they'd be the people there with a very sensitive
Fantastic.
radios. If it was.
When you mention connecting to HIEs, are you connecting to private HIEs, or are you also connecting to public HIE?
We can do both.
Regional.
It's completely up to the customer. We've got conversations going on in a number of different places right now, them wanting to bring the data in. We've got a couple places where we feed data to HIEs today, but it's across the board.
And have you connected to the local Texas?
We have not.
Any others? I've got one. You mentioned Commonwealth, and anytime people mention Commonwealth, I always bring up fire. Not fire like ambulance fire.
The other fire.
Fire on fire. So to what level of integration would you be once those systems are fire compliant? How would that change anything?
I'm going to let Jim, if he wants to address that.
All right.
We have not done fire yet. One of our competitors is playing in that space. We think it's a space that we're going to eventually do, but Jim Keene is our VP over development.
Yeah, we're still going through the use cases now, but the net result is, in order to get certification, our system has to be queryable, and we have to be able to submit queries to Commonwealth in order to get the two-way data exchange working.
Yeah, so I guess there's two things there. Fire is a transmission mode, but then Commonwealth is an entity. Commonwealth, I guess a number of years ago, 5 large EHR vendors at HIMSS stood on stage with the director of ONC and committed to playing well together in the sandbox and making interoperability really happen among EHR vendors. And so Commonwealth is an initiative. Those 5 now have grown to, I think, 35 EHR vendors who are working together, promulgating standards to be able to do. One of the primary things is patient matching. So you show up at your doctor, they would have the ability to query Commonwealth, pull down some episodes of care and go, is this you, is this you, is this you? Link those to your profile in their system and be able to pull down information, as well as send up information now from your care visit to that repository. So I think the jury is way still out on Commonwealth, how it will end up, but there's a lot of collegial work being done right now that even if it doesn't come to fruition as an entity, that groundwork hopefully will help long-term patient data follow you from provider to provider.
Seton's actually implementing it as we speak, so it's coming.
We're recording it. How are you handling in the EMS when there's more than one guy in the back of the EMS and you've got 2 people doing that charting? Are you guys trying to collect on that, per user?
Absolutely. You're charting multiple patients. It's not just in the back of the ambulance, but at the scene, I may transport 1 patient, stick 1 on a helicopter, and have 5 other people who refuse care. So there's a chart created for each one of those. And the 2 providers on there, it depends from the agency to agency where they have 2 devices to do collection on. In some cases, I know some agencies who are very limited in their resources may do some paper charting on the side of the road of, you get name, address, date of birth, have you sign the refusal, enter the chart back at a workstation, and then scan that signed refusal in. So a lot of different permutations of that. The services with the resources, each of the providers is going to have a computer and they can go through it.
Great, thanks, Aaron.
You had to be across.
Yeah, really. I feel like Vanna.
It's part of the HIMSS wellness strategy.
Yeah, I'm getting my steps in. I feel like Vanna White.
Yeah, what is the granularity on the origin, the patient origin? I mean, are we talking down to where they actually were found at their, where the record was created, or where
No.
actually the patient
Where
experienced
the
their-
address of the ambulance was dispatched, you'll actually get the street address as well as the Latin line for that.
Okay.
So you can pinpoint it on the map.
Cool.
And the agencies use that to really monitor their response data and their response times and where do we need to have our assets, time of day. And there's a cool program that puts it up as a Doppler radar map. So as you scroll through the day, you can see the colors change of where their density is. And so they live and die on that data.
Give me some lead time.
What about getting information on patients before they have an emergency? Like, I know there's Smart 911 as a registry where patients can go in and enter in data. Do you have programs like that?
We don't specifically ourselves. Many of our customers do utilize Smart 911 and several other programs like that,
Okay.
where the patient can go and self-enroll. Most of the major computer-aided dispatch programs have the ability for, let's say you just bring home someone with a medical special need, and you can notify the ambulance service. They'll build in your address data about it, and they can upload specific physician orders and so forth that can then be made available to the crew if the time is needed. So.
Don't worry about it.
It scares me.
H.E. had an epiphany. Okay.
So that actually gets me thinking about mobile solutions. Have you thought about maybe hooking into like secure messaging providers like TigerText to be able to text the attending trauma surgeon when you have a trauma coming in? Because you know Dr. Ware likes to sleep a lot.
Sure. They all do.
Yeah. So texting him, letting him know that a trauma is coming into Williamson, something like that.
There are a couple solutions on the market specifically around stroke and STEMI that activate teams. My personal experience in dealing with the Dr. Wares of the world is that they really want that activation. They want the field data to determine whether they activate or not, but they really want a gatekeeper in the hospital to flip the switch, typically. You'd have to have a really... Yeah, so we have the ability to send those alerts to the hospital today. An ESO user can enter a very minor amount of data, so age, sex, primary impression, the facility I'm going to, my ETA, and then I hit the type of alert it is. And so if it meets the local trauma criteria and they hit trauma alert, it will alert the hospital. And then the hospital have the ability to forward that on to activate their systems. But field activation of those teams is really important. The physicians, especially when you're calling it resources outside the hospital, there's a price tag attached to that. They're very sensitive to false activations. If we're only activating in-house resources, it's not so bad because they're already there.
Any more questions?